Okay, hey everyone. So we are up and running. So if anyone has any questions, throw them in chat. Where to start? So endocrine, make sure you understand the different classes of the hormones. Not seeing chat. Okay. So classes, make sure you know peptides, amines, and steroids, know the differences as far as how they're created, how they're stored, and how they're transported. Transport is a big one. Make sure you know which ones are water soluble. They can dissolve in the plasma. Which ones are lipid soluble. They need carriers to get around. Make sure you understand also about proteins. When they bind, they're not active anymore. So the free is the one that you want to know. Make sure you know the negative feedbacks for the different hormones. Okay, first question has to do with... Okay, so first one is vitamin D. Let me pull up my vitamin D stuff. So vitamin D comes out when PTH is released. So it causes vitamin D to be activated. Because think about what PTH is doing. It comes out when calcium levels are low. So PTH comes out, gets stimulated. It's going to go to the bone and start reabsorbing the bone to bring calcium and phosphate in. But we need a way to turn off PTH as well. So what vitamin D does, it comes out. It also helps with calcium. It's going to help absorption of calcium in the small intestine and also help reduce or increase the reabsorption of calcium in the kidneys as well. All to bring up calcium. But what vitamin D will do is when calcium levels hit a certain level, we're good. Vitamin D will throw all the extra calcium right back into the bone, and then we get back to our calcium levels. So remember, the calcium in the blood, the calcium levels in the blood is what matters. The bone doesn't, but we still need to protect our bone. That's where vitamin D comes in. So I hope that answers your question about that. Slide 47 in endocrine. Let me just get to that. The clinical correlation there with the cretinism and dwarfism, just for both of them, it's just when you don't have thyroid hormone, you have a lot of growth and development issues. And those are two examples. That's just having to do with thyroid and what happens with thyroid. So the next question is about calcium levels with regarding to liver failure. So we mentioned before, let me get to my calcium here. Okay. So with regards to calcium, 45% is free, meaning it's floating around in the plasma doing its own thing. Ionized, calcium 2+, 45% is free. And we want this range to be 4 to 5.2 milligrams per deciliter. Another 45% of the calcium is bound bound to a protein. If you don't have proteins being created because you have liver failure, you have less proteins to bind, so therefore your free calcium is going to go up. You're going to have hypercalcemia because nothing is being bound to the protein. It's going to be free, and that's going to cause your calcium levels to go up. And next question has to do with umbilical and fetal blood. It's going to be, as far as, I'm not going to ask you that question as far as if it's the vein or the artery. That's an anatomy question. Just know that you have the maternal blood, and we have one cell layer thick here, and then you have the placental blood. And you have that layer. So when we say 2 layers thick, here's one, there's 2 layers. And those are the 2 cells thick that mixes, and obviously, you know, O2 goes into placental blood. The CO2 from the placenta will come out, go to the paternal blood to get out. Obviously, that's where all the exchange is going to happen. And different function of hormones, but a lot of them have to do with increasing gluconeogenesis. So think about what the hormone is going to be doing. Cortisol is a stress hormone. It's going to raise glucose in the blood because we need glucose, we need sugar in the blood to feed the muscles from whatever we're doing with regards to the stress environment. That is going to do that. Glucagon is a storage hormone. It's a fasting hormone. Comes out when we're fasted. Why are we fasting? Because we haven't eaten any food. There's no glucose coming into our body. Our body's going to need it somehow. Glucagon comes out. It's going to start making glucoses from other things. Insulin. We know all you got to know is insulin is to get the glucose out of the blood. What processes in an exam question where the answers would be, how is this sugar getting out of the blood, or is it going into the blood? If it's going into the blood, it's got to be going in for a reason. Why is this glucose being dumped into the blood? Is it fight or flight response? Is it long-term stress response from being in PA or AA school for the first time and being stressed out with all the exams and everything? What is it? What's going on? Why is this going to happen? So I hope those answered your questions. We're caught up now, I believe, as well, with the questions. And just remember also with this whole PTH thing, that when the phosphate comes out, it does increase the excretion of the phosphate because we don't want that phosphate floating around. So we get rid of it so we don't have that phosphate. Okay. Okay, 69 to 71. Okay, so 69 to 71 with regards to alpha and beta affecting cyclic AMP. Okay, so when we talk about cyclic AMP, what is it going to be doing? Causing constriction or causing dilation when we deal with that? Let me just go with this. Okay. Okay. Causes constriction. Or dilation. Right. Cyclic AMP is dilator. So when we talk about these betas and alphas, let me get to the slide again. So we talked about alpha receptors. Alpha 2 receptors, what they do is they suppress cyclic AMP. So if we have stimulation of these alpha 2 receptors, it's going to suppress cyclic AMP, causing constriction. Isn't that what norepinephrine does? Causes constriction. And how it does it? By suppressing cyclic AMP. There's no dilatory component anymore, so we're going to have constriction. Now, we talk about betas and beta 2s and beta 3. What they do is they increase cyclic AMP. Now, remember, who has the higher affinity and who's going to trigger these betas more? This is going to be your epinephrine. And what does epinephrine do? It causes vasodilation of the skeletal muscle beds. So remember, during a fight or flight response, we want to shunt blood away from things we don't need. Our splanchnic system, GI, we don't need to be having blood going to the GI system. We can shunt it away, put it to our muscles. Well, how do we do that? Norepinephrine causes the constriction through suppressing cyclic AMP, and then epinephrine will cause the dilation through increasing cyclic AMP. So I hope that answers your question regarding cyclic AMP. And why is it that 21 alpha hydroxylase and the 11 alpha hydroxylase are not expressed in gonads? So they're not there because we need them in the adrenal cortex so that it can make our aldosterone and cortisol. That's just the function of the gonads, is to just make testosterone and the estrogen. Don't have the enzymes there. You want all the products of all the steroids to go to estrogen or the testosterone. So they're only located in the adrenal cortex because that's where those enzymes are located. So there are other enzymes, but like 21 alpha hydroxylase is kind of like the gatekeeper. If you remember the picture I showed with all the different steps involved when you go from one hormone to the next, the products. Make sure you know that the conversion of cholesterol to pregnenolone is the rate limiting step. And then after that, it gets to whatever these enzymes are. That's when you start going down the different lines. Gonads don't have those enzymes. And inhibin is always the same in males and females. It's only going to have a negative feedback on FSH, but it does do it in males and females. And ovarian and uterine cycle. So, ovarian, the first half is under the influence of follicle stimulating hormone. It's the follicular phase. What we're doing here is maturing the follicle. Okay, when this follicle is being matured, it starts producing estrogen. Estrogen normally has a negative feedback, but when you start getting the follicle becoming more and more mature, these theca cells start dumping out a ton of estrogen, and we get a surge in estrogen. This estrogen surge goes above threshold. And it causes the LH surge. And this is where ovulation occurs. That's where ovulation occurs. So now we're in the luteal phase because now luteinizing hormone has taken over. At this area, in the luteal phase, we have the corpus luteum. Corpus luteum will make progesterone. It will continue to make progesterone in the presence of HCG. If there's no fertilized egg, nothing is making HCG. Nothing will keep the corpus luteum alive, and it will involute and degrade and turn into the corpus albicans. And once the progesterone levels drop, we'll see what happens in the uterine cycle in a second. So this is the ovarian cycle. The follicular phase, under the influence of follicle stimulating hormone, we are maturing a follicle. Those theca cells are getting more mature, dumping out more and more estrogen. We get above threshold, we cause an LH surge, there causes ovulation. Now the egg is gone. We're left with the corpus luteum, which is the leftover follicle that will continue to produce progesterone in the presence of HCG. If it's not there, progesterone levels drop and the cycle will begin again. Now we also have the uterine cycle. Okay, while the ovaries are in the follicular phase, the uterine cycle is in the proliferative phase. Okay, the lining is growing at this point. The endometrial lining is starting to grow under the influence of this estrogen that's being secreted, and the lining gets a little bit thicker and starts to get ready for a fertilized egg. Once ovulation occurs, the egg is now free, gets caught up by the fimbriae of the fallopian tube and brought up for its journey into the uterus. While the progesterone is going on, let me change the color. The uterine cycle turns into the secretory phase. And this is under the influence of progesterone. Highly vascular at this point. Lots of blood vessels being grown. Getting that lining really fluffy at this point, waiting for a fertilized egg to show up. Once the corpus luteum starts to die off and the progesterone levels drop, then the next phase, which is the menstrual phase. The menstruation begins. So proliferative phase, secretory phase, menstrual phase are all uterine cycle properties. Follicular phase, ovulation, luteal phase, those are ovarian cycle properties. So make sure you, again, just like we went through that Wiggers diagram, understand how things are going across with the ovarian cycle, and know also what's going down. So while the ovarian's in the follicular phase, uterine's in the proliferative phase, getting the lining ready for a fertilized egg. While the ovaries are in the ovarian cycle for the luteal phase, the uterine is in the secretory phase, waiting for that fertilized egg to come. Okay, so I hope that answers the question with regards to the cycles. Next question is discuss aldosterone and the synthesis of other hormones. Okay. So, stimulus for aldosterone. What are the causes for aldosterone to come out? The main one, obviously, is low effective circulating volume, sensed by the macula densa in the nephron. So we get renin release. Renin provides the cleavage of angiotensinogen to angiotensin 1. Angiotensin 1 is then converted angiotensin 2 by your ACE, angiotensin converting enzyme. Now, this angiotensin 2 goes to the adrenal cortex in the zona glomerulosa, where it binds to the AT1 receptor, where the enzyme to make aldosterone synthase provides that boost to get to aldosterone. Okay. Make sure you know also that ACE is mainly found in the lungs. That's where ACE is. So that is the cascade for the renin, angiotensin, aldosterone cascade for those hormones. Okay, let me go to that one. Okay. Okay. So, question has to do with inhibin and estrogen. So let me pull up that one. Where's my slide? Okay, I can't find my slide. They're secreted from the ovaries. They just have special cells, but I can't remember what the cells are. I don't think I had that slide. Yeah, you don't have to know what type of cell it does. Just know that inhibin will only inhibit FSH. Whereas the testosterone or the estrogen will inhibit anterior pituitary and the hypothalamus. So we have GnRH goes to anti-pituitary. FSH and LH. FSH, again, they both go to the gonads, but in males, FSH will go to the Sertoli cells, where they will start making spermatogenesis and making new sperm. But the inhibin that it produces only does FSH. LH testosterone or estrogen, and they're going to have their negative feedbacks on LH and also GnRH as well. Okay, I think we're caught up on questions. So if I left anything out on the ones that I already answered, please let me know, and I can readdress the question. What else here? Know about spermatogenesis, know where they start, where they mature. The different things that help cause emission and ejaculation. For female, know against the cycle we already went through. Know about obviously all the hormones, the cycles, adaptations to pregnancy, fertilization, where it occurs, talking about implantation of the blastocyst, crossover from placenta, from the ovary. So the question is the synthesis of weak androgens from the adrenal glands and how that overlaps with the ones producing the gonads. They really don't overlap per se. It's more that they just will. Let me get that slide. Okay. Cholesterol will go to pregnenolone. Pregnenolone is now going to be the one that's going to do things. However, when it gets to pregnenolone, most of the stuff is going to keep going down to make aldosterone or going to make your cortisol. But to get through that window, this is where you need your 21 alpha hydroxylase. If you don't have this enzyme, then this pregnenolone will make its way into weak androgens. They don't really do much, especially in males, because the testes will do all the testosterone. It's a lot stronger of a steroid than these weak androgens are. In females, again, they don't really do much either because the ovaries make all the estrogen for you. Where this becomes a problem is if you don't have this enzyme, all the products go to the weak androgens. Especially in females, you'll start seeing some secondary sex characteristics, extra body hair growth, because they're getting these weak androgens being in a much more their overproduction. So it causes like hirsutism, hair growth on the face, things like that because of the excess steroids. Normally, they should not really be made very much in the adrenal cortex because the ovaries do it all for us. Okay. Okay, next question. Feedback loop for growth hormone and IGF. Okay, so always start at the top. Growth hormone, releasing hormone. We'll then go to the anterior pituitary to release growth hormone. This growth hormone will be released and will also cause the release of IGF-1. Growth hormone, remember, is in a pulsatile fashion. It only comes out a little bit at night, or at night is when it mainly comes out. And then after that, it drops down. But the effects of the IGF-1 linger, and they will provide feedback as well. So what happens is growth hormone will have a negative feedback on the hypothalamus. The IGF-1 will have a negative feedback on the anterior pituitary and on the hypothalamus. So that is with regards to growth hormone, IGF-1. And then when you talk about primary, secondary, and tertiary endocrine disorders. So GHRH is the hypothalamus. Pituitary, and just for the sake of this example, let's pick thyroid. Okay, we know an axis exists from this to that, to that. So we know that's there. If the patient has an issue with the target tissue, the end result it's the primary problem is the thyroid gland itself. If the pituitary gland is the problem in this case, it's a secondary issue because it's the second one up in the hierarchy. Finally, tertiary problems are usually going to be the hypothalamus. That's the third level up from the target tissue. So main ones, thyroid, adrenal cortex, those are the primary lesions. If you're talking about growth hormone or you're talking about what else comes out by itself? I can't think right now. But anyway, then the primary itself is the pituitary gland because that's the only gland that comes out with the growth hormone. There is no target tissue for growth hormone to come out. It just comes right out from the pituitary gland. So those are the hierarchies. You have to know the hormone to know, in this case, if it's thyroid, you have 3 levels. If it's growth hormone, you only have 2 levels. This will be the primary, and that's the secondary problem because of the way growth hormone is released. Next question is about POMC and MSH. So POMC is a precursor molecule that will dissociate to make ACTH and your melanocyte stimulating hormone. When you have low cortisol, there's no cortisol coming out by yourself, your adrenal cortex isn't making it, your ACTH levels are going to skyrocket because it's trying to get the adrenal cortex to do something, and ACTH is the stimulating hormone for the adrenal cortex to get that cortisol out. So when you have very, very low cortisol levels, we need a lot more ACTH. Well, in order to make a lot of it, you need a lot of POMC. One of the consequences is that MSH goes along for the ride. So when people have certain diseases where they have very, very low cortisol levels, they get hyperpigmentation in different areas because of the MSH. That's all you got to know about that. Emily, I am not going to go that detailed in this class. When we do endo next winter, yes, for sure we will. But for now, no, just understand primary, secondary, tertiary. Don't go crazy learning those things up and down. And fertilization and pregnancy. Okay, so mainly occurs in the ampulla of the fallopian tube. That's one of the big ones to know about that. Know that the fertilized egg, the blastocyst, takes a couple of days to get into the uterus, where it's going to embed itself into the uterine lining. That blastocyst, as long as it's alive, will just continue making HCG, which we know is going to stimulate the corpus luteum, keeping it alive to continue producing progesterone and estrogen until the placenta is matured and ready to take over the production of those hormones. It takes about the first trimester for that to happen, 10 weeks or so, for that crossover to occur, where the majority of all these hormones are produced by the placenta and not the ovaries anymore. We talked about molecule exchange already. Maternal adaptation to pregnancy, know what normal things should happen. I'm not going to say how many pounds are gained in each thing. Know a normal body weight change, know normal what happens in metabolism, blood flow, respiration, their GFR goes up, coagulability, because they don't want to have any clots. Or to protect them from hemorrhaging, to prevent them from bleeding out during delivery, they do become hypercoagulable later on. Constipation due to the progesterone, parturition, the delivery of the baby. Know the phases of uterine activity. Okay, it's phase 1 through 3, 0, 1, 2, 3, 4. I'm sorry, 0, 1, 2, 3. So make sure you understand the different ones for that. No lactation, what causes it. Know the suckling reflex, why that works. And that was pretty much it for that. Okay, countercurrent mechanism of the kidney. We're not covering that in this unit. So, has to do with concentrating the urine and conserving water. Okay. There. So differentiation of the sexes. At first, we have these indifferent gonads, and they can go one of two directions. With the presence of testes determining factor, they will turn into testes. Without the presence of TDF, you will get ovaries. The testes will then start secreting testosterone, but it also starts secreting Müllerian inhibition factor. This Müllerian inhibition factor is going to have a role pretty soon, and we'll get to in a second. In the ovaries, because obviously they're not testes, they will have no testosterone, and they will also not have any of the Müllerian inhibition factor. So, what happens next? In the presence of Müllerian inhibition factor, we have the Müllerian ducts. Because we have the Müllerian inhibition factor, this whole thing in males degenerates. In females, because they don't have the Müllerian inhibition factor, these Müllerian ducts will turn into the uterus and uterine tubes. The next thing that happens are these Wolffian ducts. I'll put over here, plus. In the presence of testosterone, the Wolffian ducts will turn into the epididymis. Epididymis. I think I spelled that wrong, but you know it. The ductus deferens and ejaculatory ducts. All because of the presence of testosterone. These Wolffian ducts in females that do not have testosterone, these degenerate. So those are the two big things. Other embryonic structures, let's put over here. In the presence of testosterone, we get prostate, penis, and the scrotum. On the female side, again, no testosterone, so those other structures will turn into the vagina, labia, and the clitoris. So that is essentially kind of what happens for sexual differentiation in the presence of the testes determining factor, then the effect that that has on that Müllerian inhibition factor. Okay, we are caught up again. It's not a lot of hard material on this one. It's just a lot of material that you have to know with all these hormones, get them straight. So like You know, tomorrow when you start your test, just start drawing everything you know when the test starts. Don't do it before. If I see you doing it before, I'll take the paper away. But once they give you the password and the test starts, just start your make up your own table. GnRH, FSH, and LH. TRH, CRH. Remember, all the releasing hormones come from the hypothalamus. GHRH. Then we have TSH, ACTH, growth hormone. Then you take it down a step further for the ones that need it. T3, T4, cortisol, IGF-1. Next, you can even do estrogen, testosterone. This way you have your levels. And then draw in your negative feedbacks. Cortisol goes to both. ACTH will also go up there. TSH go there. TSH by itself will go there. Draw your negative feedbacks early on and everything so that you have your hierarchies done and you know what to do for those questions. So you can do that as soon as the test starts. You don't need to know the chemistry of the androgens. Just know that the aromatase is the enzyme that makes the estrogen, and it's only located in the ovaries. Like, for example, stuff like that. That you got to know. So in the theory of labor, what they think is that it's the fetal androgens that come from the adrenal cortex that initiate the start of labor in the mother. I guess that's one of the last things to kind of mature, and if at that time, I know the lungs are almost the very, very last thing, but the steroids have to come out too. That's why if you're preemie, we give you a lot of steroids to help your lungs develop. Probably you needed some sort of steroid showing that, you know, the adrenal cortex is mature enough where it can produce androgens, so therefore the baby's ready to go. Okay, prostaglandins and oxytocin. Okay. Where's my notes? So they kind of work together. It's not a one or done type of thing. They both work together to get the baby out. Prostaglandins are the uterine contractions, and oxytocin, the expulsive stage of labor, that last bit getting all the products of labor out. All the placenta has to come out of the uterus. Can't leave anything behind. So oxytocin provides that last little bit to get everything out. But they both work to get it going. Question about somatostatin, just know that it stops things. It's going to be the inhibitory for the growth hormone as well. but you don't need to know anything as far as how it comes out of the delta cells. But make sure you understand um, beta cell and alpha cell in the islet of Langerhans and how they are set up in a way that when insulin is being released, it suppresses all the glucagon because of the way the structure of the islet is. Blood comes up through the center, spreads out through the islet, bathes over the glucagon cells, and insulin shuts it off. So you gotta know that. And then onset of puberty and how FSH and LH changes over time. Just think about for onset of puberty in females, starts the cycle so that every month you'll always have, where is it? Here. Okay, so here's our plasma concentration. Okay. When puberty starts, LH cycles. Every time you have a peak, that's an ovulation because LH surge causes ovulation to occur. Follicle stimulating hormone kind of just wiggles around, does its own little thing underneath. But once you hit menopause, they start going up. There's your onset of puberty. And in females, the cycle keeps going on and on and on until menopause hits. Okay. I think we're caught up now on those. Okay, we're caught up on questions. What else for endocrine? Know your secondary messengers. What else? There won't be any ADH questions. That was all taken care of in renal. So no ADH. Make sure you know the different zones, what they're called, and what's done in each area. You don't need to know the clinical correlation with regards to like the synthetic corticosteroids and like which ones are like more mineralocorticoid. That's for endo. We'll do that then. Know what hormones we've talked about have those circadian rhythms. So cortisol was the big one. Know the Renin cascade. Pancreas, no synthesis of insulin with regards to C-peptide. Know all the target things that insulin does. As far as the clinical correlations, insulin is important. You don't have to know the classes for insulin drugs. Don't worry about that. Slide 53. In which lecture? Not that one. Eicosanoid pathway. Okay. You don't really have to know that much detail for this class. You will have to know it for Dr. Wood, though, eventually. The big thing is we have these secondary messengers derived from arachidonic acid. They are the leukotrienes, prostaglandins, thromboxanes. Those are secondary messengers that are derived from arachidonic acid. They're different from secondary messengers because they are the hormones themselves. But we can alter the pathways. The precursor is arachidonic acid. Arachidonic acid will go through two pathways, the COX pathway and the LOX pathway. The COX pathway is going to give you your prostaglandins. And your thromboxanes. The LOX pathway is going to give you your leukotrienes. That's really all you have to know. That's as far as you got to go with that one. We can block the COX pathway with NSAIDs. Block that pathway. And there's other drugs that we can give that block the LOX pathway, but NSAIDs are a big one that prevent prostaglandins. Okay, we're caught up on questions. Some of the other clinical correlations were regarding like the PDE5 inhibitors and PDE3 inhibitors. I'm not going to ask you about that, but just you know what PDE3 is. You have to know what PDE5 is. You have to know what they do. If I just say we inhibit that, what's going to happen? So you don't need to know it. I'm not going to ask you about Revatio or sildenafil, but if there is a question on there with regards to that, you can figure out what a PDE3 or 5 is. That you should know. So if I inhibit it, the opposite effect of what you want is going to happen. Any other questions? here. Wait a few more minutes. Nothing comes through. We'll end the stream early. So you guys are almost done. First semester. A couple more exams and you guys are done. And then over break, do nothing. Just relax. Catch up on sleep or whatever you want. Okay, there's no more questions. I'm going to take off for the night. I'll see you guys in the morning. Again, straightforward questions. Just keep those hormones straight. Know which ones are releasing. Know which ones are stimulating. Know the negative feedbacks. Know the uterine and ovarian cycles. Those are the big ones. Questions are mostly, know the pathways. What stimulates what? And you'll be set. Okay. Have a great night, everyone. Good luck tomorrow morning, and I'll see you then.